Before we get started, just want to make a couple of announcements. First of all, as you see on the screen here, we have the Privacy and Security Forum right here in Boston. This is a national level Himss conference, December 1st through the 3rd. So if you were not aware of that, this is coming up in a couple of weeks, and it's a great event. Just want to make sure everyone is aware of that. We also have coming up on December 3rd the New England Chapter Himss holiday event. So please go to the website or check your email and register for that. It's a great event every year, and look forward to seeing all of you there. That will be our last chapter event this year, and we'll be rounding out the year on a strong note. A couple other things, we do record all of our events. I've had a couple questions tonight about that. Come visit us on our YouTube channel, and you'll see all of the past topics and presenters and speakers. It's a great channel, and thanks to Matt Bornstein for helping with all the recordings. And thank you, Matt, your communications chair. And then lastly, if you haven't already done so when you checked in, if you did park here in the garage tonight, we have discounted parking vouchers that we'll give you, so you can, I believe it's $8 for parking, so give you a little discount there. And without further ado, I'd like to ask Jay Adams to introduce our guest speaker for tonight. Jay?
Hi, my name is Jay Adams. I'm the treasurer for the New England Chapter of Himss, so I'll be paying for all of this at the end of the night. And I have the pleasure of being able to introduce Judy Runs tonight. We're really, really happy to have Judy speaking on this topic that's very relevant to what a lot of us do in our day-to-day jobs. So I was talking to Judy earlier. It was very interesting, and I didn't realize this. She is currently in the process of implementing a large electronic health record called Epic that some people are familiar with. And she has been doing this with Epic, and I didn't even know that Epic was around this long, since 1991, at Harvard Pilgrim, which was one of Epic's first big clients. So she's done that for, all these years. 1991, I was in second grade. So we're really happy to have her. She is local. She works for Atrius. She's a Brandeis grad, and she is currently the director of electronic health record operations for Atrius, which I believe is the umbrella for many, many small physician practices in our community. So without further ado, glad to be able to introduce Judy Runs.
Thanks, Jay. I was in second grade also.
Me too.
So thanks everybody for coming tonight. It's great to have you here. And my goal tonight is to share some practical ideas of how to help your users and physicians and clinicians adopt the helpful features of electronic health records. I also want to talk a little bit about some theory behind it, some adult learning ideas, and a little bit about cognitive psychology that will help you have some context for how to smooth an implementation. So about 6 years ago, I moved out of my comfort zone in IT into a new job where I was reporting up into operations, up through the COO. And it's really been a great job at the intersection of systems, process, and people. And I've learned so much. I've really enjoyed this job. And I just want to say a few things in advance. A lot of what I'm talking about tonight is really the collective wisdom from my team. I have an excellent team. I am not going to mention the EHR we're on, although Jay gave it away. This is system agnostic, so it really applies to any EHR that you're working on. And I'm going to talk about some things that didn't work so well, in addition to what works well in our experience, because I think both are instructive. All right, so here's what more detail I want to talk about is why is testing more than testing and really critical to a smooth go live. Some strategies for adult learners, because adults don't learn very well. They need a lot of help. And you know, if you're in the business like I am, working at a provider organization, you should think of yourself as a marketer to help improve the adoption of useful features. Oh, and I want to make tonight fun and interactive. If you're like me, you got up early this morning and you worked all day, and then maybe you've come here. I did not have a glass of wine, but I think many of you did. So, you know, I'm trying to make things fun, and there will be some volunteer opportunities. Okay, so just a little bit about Atrius Health or Harvard Vanguard. It's a large ambulatory practice in and around Boston, around 20 locations, about 35 specialties. And one thing that makes it a little unusual is that pharmacy, lab, and radiology are on site in most of the sites. We're about 1,200 clinicians, MDs and mid-levels like NPs and PAs. And this year, we merged with ourselves, is what I like to say, where it was 3 separate medical groups, with Harvard Vanguard being the largest, and now it is one organization with one billing ID and one board. So this is one of my favorite stories. This was a number of years ago, and we were doing a system upgrade. It was a system upgrade that involved a lot of downtime, like 36 hours over the weekend, and everyone's working hard, and it's late, and it's overnight. And finally, we finished testing. It's good, the interfaces are coming back up. We're ready to release it to the users. And the project director said, "We're done." And I was like, I think we're just getting started, because we're releasing it to the users now. So I always, that always stood out, that that's not really when you're done. That's, in a way, that's the start. So when I moved into this job, I had a steering committee, and I asked them to tell me, what did success look like? And this is what they told me. So once live, the change works as planned. Right? That sounds simple. That's really about testing. That training is appropriate for what the change is. If it's a big change, you explain it. If it's a small change, maybe it's just a communication. That everybody knows the change is coming. I don't know if you've ever had the situation where you do an upgrade and somebody says, "I didn't know we were upgrading." So we're going to avoid that. The reason for the change is well understood, and the benefits are clear. So we have to do ICD-10, it's a federal requirement, or we're making this change because it will help support our quality metrics. So let's jump into testing. And it's, I think, can be a very underappreciated work effort, where sometimes maybe seen as the uncool, maybe it's not creative enough, repetitious, but nothing could be farther from the truth. It really takes smart people who know a lot. And this can demonstrably improve the smoothness as you make a change. You know, traditionally, IT would provide scripts. You can follow the scripts. Does it work to spec? But I think the key to success in an EHR environment is the user acceptance cycle, and that involves watching and listening to people. Because you know, software, it's bits and bytes, and it works like the programmer told it to work, right? It's just going to do what it said it thinks it's supposed to do. But people, you never know what they're going to do. They always surprise me. So part of the user testing is really watching and listening to your users. What's hard about what they're doing? What's easy? Why are they doing it that way? Is there some way we can make it easier? So I'm going to read a quote that I found as I was getting ready for this talk, and then we can see if you can guess who said it. So, designers must watch people use the program in person because 95% of the stumbling blocks are found by watching the body language of the users. Watch for squinting eyes, hunched shoulders, shaking heads, and deep, heartfelt sighs. When a user hits a snag, he will assume it is on account he is not too bright. He will not report it. He will hide it. Do not make assumptions about why a user became confused. Ask him. You will often be surprised to learn what the user thought the program was doing at the time he got lost. So this is like a famous bunch of developers who have a really good user interface. Anyone want to take a guess?
Google?
Not Google.
Apple.
Apple, yes. This was Joe Myers and Bruce Tognazini. And they wrote this in 1982 when they were developing the Apple II. And I thought that really described, that's why I have these people, you know, with different reactions as they're sitting at the computer. So as you're doing your user acceptance testing, it's really important to have a good process to log the issues, because that's gonna really help you in the next steps. So here's some of the steps we take. And first of all, the folks that are testing really need to be involved from the very beginning. They need to be there in the design, thinking through the use cases, and getting ready and thinking about how are we going to do user acceptance testing. So if you don't already, you should have a user acceptance design step in your project plan. You might need to identify who are the users. Is it just cardiology? Is it all nurses? Who are the people that are most impacted? And get that scheduled in advance, of course. Clinicians are always really busy. So you need to make sure you can get that time. And then how will you run the session? Are you going to bring your computer to them? Are you going to set up a lab? Are you going to go sit in their office? How are you going to actually do it? And then do it. So after you go through user acceptance, here's some of the categories we've found really useful. So you may find a workflow issue. When we were implementing like a dashboard notification for our ACO, we were tracking different things needed for ACO quality metrics, and one of them was falls risk assessment. It was really simple. It was like, you know, red, yellow, green. But during the testing process, we found out some of the staff who were expected to do a falls risk assessment didn't know how. Or they didn't have the chair or the hallway. So it really required, in order for this to be successful, it wasn't IT's job, but we needed to make operationally sure that folks knew how to conduct this test. You can find things that are a really tricky training point. At one point, we were converting the underlying structure for the way prescriptions were ordered. And we found that when you, watching the users, when you ordered a new prescription, it was straightforward, it looked fine, but anything that was a refill went through a conversion, and people were visually confused by it, or it wasn't all, it didn't look right to them. And so we made that a key part of the training, and also could assure them that even though it was a little confusing, it was going to diminish with time, because the fewer refills on the old to the new, it would just get better with time. So it helped us with our communication plan. And of course, you could get a software failure, gets through the other phases, but you know, users can find all sorts of things that we may not. Okay, So it's a good time to get everyone awake. I wanted to try to do a poll. So if you want to grab your phone, and you can put in sli.do, Slido, and then enter poll number 0956. I'll give you a moment to do that, and then we'll see. This is a good user acceptance testing also. When I was trying this out with my team on Friday, it's like, oh, I can't get the internet, and what number is that? Oh, I put that in wrong. So I'll watch your faces to see if it seems to be going okay. Anybody get to vote yet? All right, let's see the magic. I could have done this with your hands, but this is like way more fun, right? Oh, there you go. Let's see. The votes are coming in. You know, to this point, when, as I mentioned, I had moved into a new job about 6 years ago, and the previous job, which was similar but different, we really didn't do, don't be shy, we really didn't do user acceptance testing. It was really when I moved into this role that I embraced it more, and when I, at some of my previous jobs, we didn't do it either. So it looks like we've got a lot of sometimes, and maybe I didn't phrase it quite well, because not everything requires user testing. But okay, we can come back. Thank you for your votes. Okay. Does anybody know who this is? This face? He's my favorite nurse, next to Lori Buswell. It's my friend from Dana-Farber. It's Walt Whitman. Very good. He wasn't actually a nurse, but he spent about a year kind of in a nursing role during the Civil War, taking care of sick and injured soldiers. So I just figured I'd pull him in. But now when I was practicing with my team last week, somebody asked me, well, okay, who's Walt Whitman? Just in case, he is a famous 19th century poet. You probably read one of his poems at least in high school. So, okay, so I'm going to tell you a story. So we implemented a software tool that was for telephone nursing triage. So to support the nurses with industry standard protocols as they're triaging calls that are coming in from patients. And it was the dream team. We had our VP of nursing. She's so engaged. She went to all the meetings. She got all the nurse leaders excited, explained the benefits. We had an excellent technical team. They were doing their project plans and delivering everything on time. And so it really was going great. So we set up time for the user acceptance testing with the nurses, and we provided them with scripts that helped them navigate through the system, and it was straightforward to them. It was very familiar because it looked just like the way they documented the telephone, but it had these protocols embedded in it. So, but by watching and listening to them, we learned a lot of surprising things. The nurses were not familiar with the protocols, the actual content. And so navigating through the system, the tree structure of these protocols was really hard for them. So then they started saying what they really thought. Where is nurse number one?
I'm a nurse practitioner with over 20 years of experience, and I really don't need protocol.
And where's nurse number two?
I handle UTIs differently than what the protocol says. So I don't want to give this advice to the patient.
So everyone was one big happy family, but once we started actually testing it, the nurses were starting to express some of their concerns about it. And, you know, I really felt like we hit the jackpot here because we realized that the training could be an e-learning. It was so straightforward and familiar that we could use the face-to-face training to talk about those concerns that the nurses raised, remind them of why the protocols were a good thing, and that had to be really communicated by nurse leadership. And we further modified the plan. We figured we might go live and there would be more concerns raised. So 6 weeks after go live, we had additional sessions that allowed us to address their concerns. We also developed a lot of reports so that we knew who was actually using it or not, and allowing the nurse managers to really follow up with them. Okay. So, let's talk a little bit about training. This is another one of my favorite stories. There was a physician conducting a training session with other physicians, and it was scheduled to be 45 minutes. After about 5 minutes, one of the doctors raised his hand and said, "You know, you've been talking 5 minutes, and I have not learned one thing." So, I was like, oh boy. But that was really a good thing to know, because I think doctors are really busy and they want their time used well, and 5 minutes had gone by and he didn't learn anything. So one of the things we've come up with is that if you are going through an upgrade or any big change, identify what are the things that they need to get through their day and focus on that before go live, and only that. You really don't need to get into what I called Captain Obvious. My kids used to say that to me when I said something they thought was obvious. But you don't need to discuss the obvious. And then there's a bunch of things you can probably just put aside as a post-go-live optimization. And that should be tied to a problem, because just showing somebody for the sake of, you know, that the system has this whiz-bang thing is probably not going to speak to him. It's going to be like the doctor who said, "I haven't learned anything yet." It wasn't relevant to him. Okay, so now we are going to do an exercise. This is the little cognitive psychology thing. So I need 2 volunteers, and you have to come up in front of the room, but I'll explain. Oh, please come up. Hi, what's your name?
My name is Rose.
Okay, Rose, you're coming here. And, can I pick a person? Yes, please come up. The audience can help you. This is hard. So it's okay. Now she comes Rose and behind. Rose, I just want to tell you something. Okay, so I am going to read instructions, and, okay.
Take it
Oh, yes. I'm going to read instructions, and then Connie is going to say them back. And you guys listen too, and help her if she gets stuck, and then Rose is going to do it. Okay, step 1. Obtain container with the items needed for processing. Step 2, separate items into groups by color. Step 3, add agent. Step 4, place group in processing vessel. Step 5, select start. Step 6, allow processing vessel to complete. Okay, Connie, take. I'm regretting this already. This is really hard.
collect necessary items into container.
Good.
Step 2, separate items according to color. Step 3, that's where I fit. Add agent. Step 3, transfer group to container or something.
Yes.
Step 4, something.
All right.
Something involving a vessel.
How do you feel?
Nervous.
All right, Rose. Now you say, well, can you say what the steps are?
Oh, boy. Gather the items, number 1. Number 2, separate them by color, or sort them in containers. Put them in the vessel, add agent,
Either way works.
close vessel, and press start.
Volunteers, Rose and Connie. That was directions for a washing machine. Oh, Jill. Jeez. So, okay, I'll explain why. Connie felt like.
That's what I explained to my husband how to do
And I know there's a debate, you put the detergent in first, or you put the clothes in first, it kind of, but that's why I said either way is fine. But I think, well, Rose got to hear it once, so that sort of makes the experiment slightly flawed. But for Connie, it was hard, and she was nervous. Okay, so this will tie back to EHRs. Okay, and this is a weird picture, and I will explain this. Okay, so many years ago, I was the project director for an upgrade that was purely visual changes. It was just, the database was the same, all the functions were the same, but you went from one view to everything's all mixed up on the new screens. And at that time, we were staffing up. I was hiring about 10 people in 3 months, and they were all new. And so we were smart enough to figure out maybe we should pilot our implementation to see if this is going to work, how we explain to people. So it wasn't piloting the software, it was just piloting the way we were going to do the conversion. And we learned the analysts were explaining, okay, this is how the new system is. Step 1, gather up all the items. Step 2, sort by color. I mean, it was essentially that. And people were completely lost and had a lot of difficulty adjusting their muscle memory. So the trainers really needed to learn the old system so they could explain the new system and kind of make the map. And if you think about, if you were kind of going along with trying to think through the steps, how you felt, you kind of like, oh, I can't remember. It's like, it's really uncomfortable. And that's how our users felt. It was so jarring for them. So the reason for this guy, he doesn't want you to see his screen. And we were not able to remove all the icons. That's how we launched the system in those days. So we would train people, but we had to sort of remove the icons in batch. So what they would do is they'd sneak back to their office, shut the door, and they'd go into the old system because it felt like, putting on your slippers and it's comfortable and they could find their way, where in the new system it was so uncomfortable. And so, there's eventually, it was tough love. All the icons went away. But I think the washing machine exercise kind of helps us keep grounded for how people feel when things change. All right, so talking a little bit about the things that you save post go live optimization. This is an example of one where we kind of did a marketing campaign. So about 2 years ago, we had a new feature with embedded in iPhones or iPads, an app that would allow you to very easily upload clinical photos right into the record instead of 15 steps using the digital camera. A few of the geeky doctors kind of adopted it. You can see we're around 100. But then we started